Everyone. Natumai wote mnanisikia. So we welcome you all to our session today. This is the oxygen therapy and critical care, the case-based series. And the following is a few housekeeping items to remember as we begin the session. So we should remember that we'll use the chat function below for question and answers found at the bottom of the screen. Please send all your questions through the chat box and also feel free to introduce yourself. And also the session is interactive. You may also be wanted to send your answers during the chat, during the discussion. If you have any IT issues, you can send a message through the chat. And also remember that this session is being recorded and your attendance is consent to be recorded. These sessions are brought to you by Assista International in collaboration with Stanford Medicine, Division of Global Anesthesia, the University of New Mexico, Department of Health Science, and Global Anesthesia and Critical Care Learning Resource Center. So after those brief introduction, I would like to welcome Dr. Saria to introduce the panelists and begin the session.
All right, thank you so much, Dr. Kevin. My name is Dr. Peter Saria, anesthesiologist working at the Respiratory hospital. This is a comprehensive community-based rehabilitation hospital based in Dar es Salaam. And today we have also my co-panelists. We have Dr. Gibbons Mwakisambwe, who is also an anesthesiologist working at Mbeya Zonal Referral Hospital, but currently he's doing his Master of Science in Critical Care. And also we have Dr. Leticia Komba, who is also an anesthesiologist working at Mbeya Zonal Referral Hospital. And we have also Dr. Rebecca Samuel, who is an anesthesiologist working at the Bugando Zonal Referral Hospital. And as Dr. Kevin said, today we're going to discuss about high flow oxygen therapy and positive pressure ventilation for adult patients. As you can see, we have majority of these patients who are in oxygen therapy. So some of them are in non-invasive methods and others are in invasive methods. But for today, we're going to talk about this high flow oxygen therapy. This is a new terminology for some of us, but it has been discussed several times, especially during this pandemic period, especially for those patients with SARS-CoV-2 infection. But remember, the high flow oxygen therapy is not only for COVID infection, it's for all patients with respiratory problems, with respiratory failure, especially the oxygenation or the type 1 oxygenation, or respiratory failure. So, and also, as I said, we're going to discuss about the non-invasive positive pressure ventilation, if possible. We're going to also discuss some of the invasive technique if time allowed. So without any hesitation, maybe Kevin, you can take us through the objectives of the session. Dr. Kevin, can you take us through the objective? Thank you so much. So these are practice change objectives. We can see we have two main objectives: high flow oxygen therapy and non-invasive positive pressure ventilation. And we have sub-objectives, I can say. Generally is to understand about the high flow oxygen therapies, advantages and disadvantages, the benefits, as you can see, the complications, how to titrate, how to monitor the patient on oxygen therapy, especially the high flow oxygen therapy. And for the non-invasive one, is an indications, benefits, and the complications. So to begin, as usual, we're going to start with the case-based scenario. As you can see, we have this patient of ours, Mr. G, who is 39 years old and present with 5 days history of worsening shortness of breath and dry cough. And his breathing is harder when he gets up and walks around. So he has tried to stay in bed and rest. He noticed that his fingers and toes are blue when his breathing is is the worst. And on the past medical history, he's obese with a BMI body mass index of 35. He is type 2 He is type 2 diabetic mellitus patient on oral hypoglycemics, and he underwent the appendectomy at the age of 20. This is the past surgical history. He has no allergy. And on the social history, he works as a house painter. He is divorced with one son aged 10 years, and he's not smoking, but drinks beer on the weekends. So this is the history. And through this case scenario, our discussion will be based on this case scenario. So please don't forget this case scenario, as it will be our guiding case. So starting with the high flow oxygen therapy, I'm not sure if Dr. Rebecca or Dr. Leticia is around, because the one who is supposed to take us through this first part of this presentation. So as I can see, Dr. Rebecca and Leticia are not around, so I can just proceed. So as you can see, we are still reminded on the PPE. This is personal protective equipment. Don't forget, when we are dealing with a patient with any who is infectious, we need to protect ourselves, and not only ourselves, we need to protect ourselves as well as to protect other patients. So we should not forget to wear the PPE whenever we are when we are instituting these oxygen therapies, especially when we are using high flow, because this is they generate some aerosol which becomes so infectious. So we are still stressing on the use of PPE. So Kevin, can you scroll up, please? So our first part will be about this high flow oxygen therapy. And as you can see, the objective is to understand the upper limit of low flow devices and how to differentiate between low flow oxygen therapy and high flow therapy. And last but not least is to understand when to escalate to high flow oxygen when you have the patient, when to escalate to high flow oxygen. So starting with the question, maybe I can ask some of us to respond to this question: which flow oxygen delivery device deliver the highest fraction of inspired oxygen concentration? Katika hizo devices zote tano hapo, hizi zote ni low flow oxygen delivery devices, as you can recall from the previous sessions. So among this one, which one will deliver highest fraction of inspired oxygen concentration? So you can just type your answer in the chat box, and then from there we can discuss. So I'll give maybe 15 to 30 seconds to respond to this question. You can just respond which you think will deliver highest FiO2. FiO2 means fraction of inspired oxygen concentration. Katika vifaa hivi hapa ni vipi ambavyo vitatoa oksijeni kubwa kwa mgonjwa wakati tunatumia low flow? I'm still waiting for your responses. Is it a nasal cannula? Is it a simple mask? Is it a nasal catheter? Is it a mask with a reservoir bag, or a venturi mask? So since there's no any response, maybe Kevin, you can just click here and see which one will deliver. Okay, so as you recall from the previous sessions, we have different devices to deliver oxygen to patients. In the low flow oxygen devices, we have, as I said, the nasal plunge. As you can see from this nasal plunge, which is the most commonly used, either nasal plunge or cannula, you can see it can be used for any patient, adult or child, and the maximum flow is 5 liters per minute. So it can range from 0.5 to 5 liters per minute. And the maximum FiO2 which can deliver is 40%. So you can see it deliver up to, 28, 40% of the fraction of inspired oxygen concentration. And this is followed by nasopharyngeal catheter. As you can see, it can be used for child and infant. So this one you cannot, it's rarely used in adults, or it's rarely used in adults. And you can see it can go up to up to 2 liters per minute, ranging from 0.5 to 4, and it can deliver 45% to 60%. This is a fraction of inspired oxygen concentration. And this is followed by oxygen mask. This is a simple oxygen mask which can be used both in adults and children. And it can be you can use a flow rate of 6 to 10 liters per minute, and it can give up to 60%, 44 to 60%, is more or less the same as in the catheter. And also after This mask, we have the mask with a reservoir. We usually call it non-reservoir, non-rebreather oxygen mask, which has the bag. So the patient, it can go up to 15 liters per minute, 10 to 15 liters per minute, give 60 to 95%. And we also have Venturi mask, which can go up to 15 liters, 4 to 15 liters per minute. This is the flow rate, and it can give up to 60%. So when we're giving oxygen to these patients, we need to know the target of our SpO2. So when you know the target, you will start with the simple devices, because oxygen toxicity, which we have already discussed. So you start with the simple oxygen device, and when we are not reaching the target saturation of oxygen, then you can escalate to other devices, to reach your target oxygen saturation. So we have all these devices, and I'm sure most of us have this in our hospitals. So these are the low flow oxygen delivery devices in their fraction of inspired oxygen concentration. Can we move on, Kevin? So based on this question, the answer will be the number D, which is the mask with a reservoir bag. Okay, can we proceed, Kevin? So we are continuing with our case. Remember, Mr. G has the following vital signs. The temperature is febrile, 38, has a heart rate of 99 with a non-invasive blood pressure of 107/88 with a respiratory rate of 28, and he's saturating 90% on a face mask with a reservoir bag at 15 liters per minute. So you can see he's on 15 liters per minute non-rebreather bag, and he's saturating 90%. So let's proceed. So now the next question is, what are the signs of respiratory distress in adult patient? Is Mr. G has this respiratory distress? Can we just mention some of these symptoms or signs of respiratory distress, especially the signs? These are the ones which are picking from the patient. What are the signs of respiratory distress? Remember, we are giving oxygen maybe it's because the patient is on distress. So as the clinician, whether you're a nurse, you're a doctor, you are an anesthetist, you need to be aware of these signs for respiratory distress. So in a few minutes, can we just go on and discuss them, or can you just share in the chat box, please? Tunaweza tukajaribu kuandika baadhi ya hizo okay, low oxygen concentration from Mubaraka Hamisi, asante sana. Kwa anamaanisha kwamba anakuwa na SpO2 inakuwa iko chini. Any other response? So Kevin, you can just click here and see, and then let's proceed to save the time. So as I said, you have to pick up some of this signs of respiratory. Okay, so HEP say use of intercostal muscles to breathe exactly. So these are the signs of respiratory distress. As you can see, the breathing rate. So when you have an increase in the number of breaths per minute, that means that the person is having trouble in breathing or not getting enough oxygen. So you are breathing fastly in order to compensate or in order to meet the demand of oxygen. So one of the signs is higher respiratory rate. As you can see, Mr. G has a respiratory rate of 28, and then the color changes. As you can see from the case, there is change in color. There's a bluish coloration either in the nails or in the mouth or in the mucous membranes. So when you have this, that means you are struggling. Your body is not getting enough oxygen. In grunting, this is the sounding produced during respiration, especially when the person is exhale. So this is the sign when the body is trying to keep air in the lungs, so they will stay open. The lungs may stay open. So we have the breathing rate, color change, grunting, nose flaring. So when you are using the extra muscles of respiration, you have the nose flaring, you have intercostal retractions, the chest retraction, extra muscles of respiration, sweating because your work of breathing has been increasing, so you'll be sweating, wheezing. This is a whistling sound produced when you are breathing. So wheezing, and also body positioning. A person may spontaneously lean forward while sitting to help take a deep breath, because this is the patient who's struggling to get enough oxygen. So these are the signs. When you see either of these, not necessary to have all of these signs, but when you can have only one or two, is enough to say this patient is in the distress, respiratory distress. Of course, as Julian said, altered mental status. This is the final. I mean, this is the late presentation. When all this fails, then the patient become hypoxic. The brain is not getting enough oxygen, and then started being confused as the oxygen is not getting to the brain. So these are the signs of respiratory distress. So maybe we can just view this video. We can just see some of these respiratory issues we are talking about. Kevin, can you just play the video? So please, maybe let's take our time to see this. So you can see there is intercostal recession because the patient is struggling. See, you can see even the intercostal, there is subcostal retraction. You see the respiratory rate has been increased. You could hear the sound. The patient is in ICU. You see those subcostal retraction, intercostal recession, fast breathing rate. So these are the signs of respiratory distress. So whenever you see this patient need immediate attention, either to be taken to ICU, or otherwise the patient get fatigued. When the patient gets fatigued, you have the total respiratory arrest, and then you can imagine what will happen. So, all right, Kevin, can we proceed? So our next question is it true, or you have to tell me if it's true or false, that high flow nasal cannula, we have seen the devices, is oxygen delivery through a standard nasal cannula at a flow greater than 6. When we are saying this is high flow nasal cannula, is it when we are using the devices with oxygen? I mean, we're using a standard nasal cannula at a flow greater than 6 liters per minute. Is it true or false? Just type in. Just type if it's true or false, please. I'm still waiting for your responses. All right, Kevin, I think we have to proceed. Maybe this is the new issues for some of our section. Okay, so high flow nasal cannula oxygen therapy. So when we are we have to first of all we have to understand the physiology of respiratory system. So under normal circumstances, we usually consume about 20 to 30 liters of oxygen in a minute. This is the normal consumption. So when we are giving oxygen therapy, when we are giving oxygen to a patient with more than this basal needs, we can say this is high flow oxygen therapy. So when we are giving oxygen more than what we usually consume, we call this high flow oxygen therapy. Pale ambapo tunazidisha kile kiwango ambacho huaga tunakitumia under normal circumstances, tunasema hiyo ni high flow oxygen therapy. Now this one is being instituted when all the measures all the devices we have seen previous have failed. Umejaribu nasal cannula imefail, umejaribu simple mask imefail, umejaribu venturi mask imefail, umejaribu the non-reservoir bag. Ina maana kwamba umeshafika mpaka 15 liters per minute with no response, or you are not getting the oxygen saturation you want, you are not meeting the target. Hapo ndo hapo utaanza kutumia the high flow oxygen therapy. In ideal, hizi ni devices ambazo zina uwezo wa kutoa up to 60 liters per minute. Yani kifaa ambacho vifaa vyetu vingi vinaishia 15 liters per minute, lakini hichi ni kifaa ambacho you can even give up to 60, hata vingine vinazidi hata more than 60 liters per minute. In ideal unakuwa na inakupa fraction of 1%. Inaweza kukupa range from 0.21 up to to 100% ambayo ni 1.0 if you want to put it in a number. Kwa hiyo na inakuwa ina humidifier, inakuwa ina hiyo breathing circuit na inakuwa ina the source of oxygen. Kwa hiyo ina maana parameters tatu ambazo utakuwa unaziseti, utakuwa una set flow rate, which rate you want. We want 50 liters per minute, you want 60 liters per minute, you want 45, whatever. So you will set your flow rate and then you will set your fraction of inspired oxygen concentration. Unataka pate asilimia ngapi iwe ni pure oxygen. Na mwisho utaset parameter ya tatu ambayo ni temperature, kwamba hautakiwi kumpa dry gas mgonjwa, lazima iwe humidified iweze kwenda isimletee madhara ya kukausha ile respiratory tract na kumletea shida zaidi. Kwa hiyo ideal, hichi ni kifaa ambacho kama tunavyokiona kwenye picha kinaweza kikatoa hiyo up to 60 liters per minute, na ni kifaa ambacho tunakitumia pale ambapo we have failed from the regular or from the usual devices we are using. Kevin, can you proceed? Kwa hiyo labda tena tuangalie tena hii video. Let's watch this video to learn more about the high flow oxygen
So
therapy.
what is high flow therapy? High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow, or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC or even HFOT or HFT or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high-flow humidified oxygen delivery device. Now, like other high-flow devices, they deliver a high flow of oxygen and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the FNP Airvo 2, go up to 60 liters of flow, while still others can go even higher. Because at the end of the day, we're just trying to meet the inspiratory flow of a patient, and when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So, should high flow therapy be a replacement to other forms of therapy like non-invasive ventilation? The answer? Absolutely not. High flow oxygen delivers just that, a high flow of oxygen. But sometimes patients have issues with CO2 or ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For example, some patients may be on high flow therapy but require more support. Clinicians sometimes escalate to NIV to prevent, if possible, intubation and invasive mechanical ventilation. And if a patient is on NIV and can tolerate short breaks, clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a Vapotherm sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high flow oxygen. Of those 104 patients, unfortunately, 27 of them failed. And of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high flow oxygen to NIV. And of the 23 patients who failed with high flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post-extubation failure were placed in one of two categories. The first category was high flow therapy only, and the other group allowed for both NIV and high flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV, but it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So, just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance, and depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a CPAP effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout. But again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
All right, thank you so much, Kevin. So I'm sure we have understand at least what is all about the high flow oxygen therapy and the devices and the setup. So maybe soon we'll be provided with the government, as you can see. As we are aware, there's a plan of establishing the ICUs and the emergency facilities in almost regional hospitals and some of the district hospitals. So soon you'll be receiving these devices. So it will not be a new things to you, and I'm sure you can just continue using it. So just an update of the case. So despite receiving oxygen by mask with the reservoir bag, remember Mr. G continued to have a fast rate of breathing, which is tachypnea, and his respiratory rate is now 36. Remember, initially it was 28 on 15 liters per minute. Now it is 36, and his saturation has fallen to 88. Remember, it was 90. Now it's 88. So the bedside provider decided to place him on high flow oxygen therapy. So this is just the second part of our discussion. We're going to see what are the benefits of high flow oxygen therapy and what are the possible complications of high flow, and how to titrate oxygen therapy. So, all right, we are proceeding with the question. So the question is, list the proposed benefit of high flow oxygen therapy. So what do you think are the benefits of using the high flow oxygen therapy? From the video we have seen, what are the benefits? So Kevin, I think you have to just click the button. So there are many benefits of using the high flow oxygen devices. So Dr. Kevin has shared the link. This is an update. So maybe some of us have access to an up-to-date website. So if you go through that website, you can have all these topics. You can just go straight to the benefits. Kevin, can you just scroll down to the benefits? So this is the link which we can use at our own time to go through the presentation and get more details. So remember, we are just discussing some of the key issues, but you can go through the literatures and learn more about the high flow oxygen therapy. So this is the high flow oxygen therapy is useful for patients who are either a pre-operative during the perioperative period, especially for patients with a respiratory failure. You can use a high flow oxygen therapy to oxygenate the patient. Some of the post-operative patients also can be benefited by using the high flow oxygen therapy. Some of the patients with type 1 respiratory failure, with respiratory distress, as we have seen, can benefit from the high flow oxygen therapy. So remember, this is non-invasive. This is non-invasive technique. So you're not putting the tube, you're not putting the patient on mechanical ventilator. All of these are the benefits, and then you can see if you are not getting where you want, then you can think of invasive techniques. So as So these are the benefits of using high flow oxygen therapy. It has some post-extubation, as I said, post-operative respiratory failure, perioperative period when the patient is having the respiratory failure, and for patient who is undergone some of the minor procedures, you can just give them oxygen through the high flow oxygen therapy. But remember, high flow oxygen therapy is not its main useness is just to give oxygen to the patient. For patient with type 2 respiratory failure, which is ventilatory failure, high flow oxygen therapy may not be useful because it will not help in removing the carbon dioxide from the body. So for patient with type 2 respiratory failure will not benefit much on high flow oxygen therapy as compared to patients with type 1, which is oxygenation failure. Sawa jamani? Okay, Kevin, I think we're gonna go back to the. So you can just go through the links and learn more about the high flow oxygen therapy and the benefits. So the possible complications, there are many complications. Some of them are acute ones, some of them are chronic ones. But for acute one, when you are giving oxygen through remember this is the high flow oxygen therapy. You are giving at least maybe, let's say 50 liters per minute or 60 liters per minute through the catheter, the nasal catheter. So one of the complications, it may cause dryness, especially when you are not using humidifier. It may cause dryness of the respiratory tract and cause bleeding. And the worst case scenario is it can cause what we call pneumothorax, and it can cause also subcutaneous emphysema. Remember, the flow is too high, 60 liters per minute through the respiratory tract. It may traverse and cause leakage to the subcutaneous tissue, causing emphysema, or it may cause pneumothorax, or it may cause barotrauma. So these are some of the lethal complication of high flow oxygen therapy. So what does it mean? We have to monitor our patient closely. When you are giving oxygen therapy through the high flow, you have to monitor your patient closely to see if he develops some of these complications. Remember, you should the issue of vasculating the chest, the issue of percussing to see if there's subcutaneous air. Monitoring the chest X-ray. If you are suspecting pneumothorax, you can just do a chest X-ray to rule out the pneumothorax. So those are the complications. Okay, Kevin, we can go back to our presentation. So as you can see from this diagram, so this is the chest X-ray of the patient with subcutaneous emphysema. You can see the air is under the subcutaneous tissue. So this is the lethal complications, So we have to act immediately to take an action. You can call the surgeons or the pulmonologist to take care of that. If you don't have, then you will wish to do something to help. Otherwise, the patient may collapse. So okay. So this is the chest X-ray of the patient with subcutaneous emphysema. So what are the 3 parameters that must be set on the high flow? I think this one has been we have already discussed. You have to set your flow rate. You want 60 liters per minute, you want 50, 45, whatever. Then you have to set your FiO2, what fraction of inspired concentration you want. And this one depend on the target saturation of oxygen you want. So if you want maybe the saturation of 90 or 92 or 95, then you may start higher. You may start with the FiO2 maybe of 50 or 60, and then you will titrate when you reach your 95, and then you can start titrating the FiO2 and see if the patient is maintaining the saturation. So if you are reducing the FiO2 and the patient is desaturating, then you'll put back the initial parameter. And the last parameter you have to set during this therapy is temperature. As we can see, we have learned that this patient needs they don't need dry air. You need to give them to humidify the air you're giving. So there's a humidifier bottle in these devices. So you have to put, you have to set the temperature. And also you have to ask the patient if it's getting more warmer. Otherwise, the patient also may become uncomfortable, right? So these are the main 3 parameters which you have to set. So Kevin, I think we've already discussed this. I don't think we need to go back. I don't think we need to go through the video. We've already seen them. So the flow rate, the FiO2, and the temperature. The indications we have seen, the indication is we have the hypoxemic respiratory failure, and these are the evidences. You know, we usually say medical. I mean, the evidence-based medicine. So hypoxemic respiratory failure there's a moderate certainty. So when should we use it? It's still debatable. This is as well as on the following extubation, when you have extubated the patient, you have to, there's a certainty. It's not straightforward if it has some indications. Preoperative period also, it has some moderate certainty, but for postoperative high flow nasal cannula in high risk and obese patient is still also moderate certainty. So these are the indication of high flow oxygen therapy, and it is strongly recommended, especially for patients with hypoxemic respiratory failure, which is a type 1 respiratory failure, and for after extubation, postoperative or perioperative. For perioperative is not recommended, as you can see, but for after extubation, when the patient needs oxygen, it's conditional recommendation. That means you have to weigh the benefit and the risk. You have to use your clinical judgment. But for hypoxemic respiratory failure, it is strongly recommended to give high flow oxygen therapy. Kevin, you can proceed. So yeah, so we've already discussed about this, and these are the links, different links or different learning material, learning website where you can go and take a look on that. All right. So we can just proceed. So which of the one of the following is incorrect regarding the parameters set by provider when delivering high flow oxygen therapy? So the A, say providers can use respiratory rate to estimate the initial flow setting needed on the high flow oxygen devices. B, providers can directly measure the flow at which the patient is breathing and match their respiratory flow demand on the high FOT device. And C, the average respiratory flow of an adult breathing at rest is approximately 20 to 30 liters per minute. And the flow rate set on the HFOT should attempt to meet or exceed the patient's respiratory flow demand. So if you were following our presentation, you can see that option B is the false one, or is incorrect. The provider cannot directly measure the flow at which the patient is breathing, and it is very rare or very difficult to match the respiratory flow demand on the HFOT devices. But we all agree that our resting oxygen demand or breathing is 20 to 30 liters per minute. We have seen that these devices, the high flow oxygen therapy devices, they exceed the patient demand at rest, and the provider can use respiratory rate to estimate the initial flow setting needed on the high flow oxygen devices. So the incorrect one is option B. So Kevin, can we proceed? And then, so at least this one, please, can we try to attempt this one? In which of the following scenario will the provider need to escalate care from high flow oxygen therapy to either non-invasive positive pressure ventilation or intubation with mechanical ventilation? Now, mbele tujaribu wote kujibu hili. A, respiratory rate does not correct or stabilize despite receiving high flow rates on the FOT device. B, the patient's partial pressure of carbon dioxide remain elevated or worsen on arterial blood pressure analysis despite receiving high flow rates on the FO2 devices. Or C, the SpO2 does not correct or stabilize despite receiving high FiO2. D, the partial pressure of oxygen does not correct or stabilize despite receiving high FiO2. And E, all of them should lead to escalation of care without delay. So can we try to attempt this one, please? What do you think is the correct answer? Or when should we escalate the care? Because our main objective is to see when to escalate the care. Tujaribu hapo hilo swali. Prosper Masawe amesema E, kwamba all of the above should lead to escalation of care without delay. Is there anyone with a different opinion apart from Prosper? Prosper says E. Is there anyone with a different opinion? Or are we all agree that option E is the correct answer? That means all the option above should lead to the escalation of the care without delay. All right, 30 seconds are over. So it's true. Option E is the correct answer. So as you can see, the patient for option A, the respiratory rate is still high despite the patient is being given oxygen. Option B, the pressure of carbon dioxide remaining elevated. Option C, the SpO2 does not correct or is not stabilizing despite receiving high FiO2. Kwa hiyo anapata high FiO2 lakini bado SpO2 haimprove. Na mwisho siku amefanya let's say ABG akaona partial pressure of oxygen high correct, does not correct or stabilize despite kwamba anapata high concentration kubwa ya inspired oxygen concentration. So all of this, that means our option is failing. Our high flow oxygen therapy is not giving what we want. So we have to escalate the care, and this is either by using non-invasive ventilation or intubation. Yes, Kevin, you can scroll up. So there's this terminology we call the ROX index, and how can it help in clinical? So the ROX index, this is an index which trying to assess the severity or if the patient will benefit on intubation or if the patient will benefit on high flow oxygen therapy. And this index uses 3 parameters, which is the FiO2, the respiratory rate, and Kevin, you just take us through the index, please. Yes, this is the ROX index for intubation after high flow nasal catheter. So as you can see, it has some parameters. It has the SpO2, you have FiO2, and the respiratory rate. So you have to put your value here. For instance, let's say our patient is saturating at 88. Kevin, can you just put 88? All right, and the FiO2, the patient was a non-rebreather, 15 liters per minute. So which can give us 60 up to 90 FiO2. So let's say 90%. I mean 95%. Let's say it's given us. So you can just type there 95. Wanatumia wana few percentage. 95%. Yes, and then the patient is breathing at 36. Remember, initially it was 28, current is 36. Can you just put 36 there? So you can see the ROX index is 2.57 points. So what does it mean? There is a risk of high flow nasal catheter failure, and this patient needs intubation. You can see from the recommendation there, the risk of high failure is high, considered. And this is clear, as you can see, the patient was put on 15 liters per minute. This is the maximum for the high flow oxygen therapy, and the patient is still desaturating. Initially it was 90, and then it followed to 88, and then as you can see, the respiratory rate increases from 28 to 36. That means we have to escalate the care, and what we need is either intubation or we can try non-invasive positive pressure ventilation. So this there's a link which has been shared by Dr. Kevin. We can go through the ROX index and learn more about that, and we can use it in our setup, right? And still using it in our setup to determine if the patient will benefit on intubation or not. So the case update now. So Mr. G is remaining on high flow oxygen therapy, the following setting. FiO2 is 100, flow rate at 60 liters per minute. The temperature is now 37. Initially, it was 38. And then after 2 days of initial improvement, his respiratory is 90. But he is more tachypnic with a respiratory rate of 35. He appears fatigued, and his arterial blood gas analysis reveals the following parameters. So the pH is 7.27 with a partial pressure of carbon dioxide of 58 and partial pressure of oxygen of 60. What does it mean? That means the patients become acidotic, right? The patients become acidotic, and which type of acidotic? It is respiratory acidotic. As you can see, the carbon dioxide is 58. So this is type 2. It's a mixed type of respiratory failure. He has both type 1 because the saturation is not improving, as also the partial pressure of oxygen is 60, and he also has type 2 respiratory failure because the patient is retaining the carbon dioxide to such a way that the patient now is becoming acidotic of the pH of 7.27. So the bedside team decided to put the patient or to try non-invasive pressure, positive pressure ventilation. Kevin, can you scroll up? Now, to take us through the non-invasive positive pressure ventilation, I would like to welcome Dr. Gibbons Motsambe to introduce himself and also to proceed with the remaining part of our discussion. Dr. Gibbons, you're welcome.
Thank you, Dr. Saria. I hope you can hear me very well.
Yes.
So
yes.
As introduced, my name is Gibbons, and we will go through the second part of our presentation using similar case, and this will comprise more of non-invasive positive pressure, non-invasive ventilation. So we have seen this precaution, and we'll just proceed further in our introduction. So thank you. Here we have some terminologies. We have NIV, NIPPV, and CPAP, as well as BiPAP. So the question is, what do we mean by these different terminologies? So we have all of them. We'll see them a little bit, but prior to that, when we talk about non-invasive ventilation, it is a type of ventilation that can be provided to the patients, mostly those who present with acute or chronic respiratory failure. Acute can be anything acutely with pneumonic changes, example or exemplified by COVID-19, which will present themselves as ARDS sometimes, as we have been seeing them. But those with chronic respiratory failure, those are patients which present with different pulmonary disorders. The biggest one of them, which is very common, is COPD, chronic obstructive pulmonary diseases. So that is one of it. And sometimes these sort of patients, they get acute on chronic. So what is called sometimes as an exacerbation of COPD. And then they retain more CO2, and then they get desaturations more and more and more, using accessory muscles, using a lot of energy to breathe, of which they can end up even getting exhausted in terms of respiratory muscles and fail even to breathe totally. So these are situations that you can find. Sometimes you might need maybe to use what is called as non-invasive ventilation. So Kevin, can we scroll up a little bit more to talk about some differences between these few terminologies that we have seen? So we have a video. Let's try to see, and then we'll proceed with our discussion.
Hello, my name is Nick, and in this video we're going to look at CPAP, continuous positive airway pressure, and non-invasive ventilation, also known as BiPAP, biphasic positive airway pressure. CPAP is a way of keeping the pressure positive in a spontaneously breathing patient's lungs. This positive pressure helps keep the smaller airways and alveoli open, which allows for additional gas exchange to take place by recruiting areas of a lung that might otherwise have collapsed down. A tight mask is applied to the patient's face to create a seal. Air and oxygen now flow through a circuit attached to the mask at high flow. The patient exhales through a valve which closes when the desired pressure is achieved. This pressure created by the valve is known as PEEP, positive end expiratory pressure. It's this that leaves the pressure in the patient's lungs at the end of expiration. There are several tight-fitting masks that can be used: oral masks, naso masks, full face masks, and CPAP hoods. CPAP has been shown to be particularly useful in acute cardiogenic pulmonary edema and congestive heart failure, where, in simple terms, the positive pressure created helps push the fluid out of the lungs and into the circulation and prevents further fluid coming back into the lungs. It could also be used for pneumonia, sleep apnea, and atelectasis. So what is non-invasive ventilation? Sometimes just keeping the alveoli open isn't enough, especially if the patient develops type 2 respiratory failure and starts to retain carbon dioxide. Think of non-invasive ventilation as CPAP with added zing. Non-invasive ventilation is used to increase the size of each breath taken by the patient. It gives an assisted push behind the breath which increases its size and thus reduces carbon dioxide levels by blowing off CO2. It seems to be most useful in conditions such as exacerbation of COPD and post-extubation on ITU. Some success has been reported with asthma patients as well as certain other respiratory conditions where there may be reluctance to sedate, intubate and ventilate a patient due to existing risk factors. So how does non-invasive ventilation work? As with CPAP, a tight-fitting mask is fitted to the patient's face, but this time the patient breathes through a mechanical ventilator. On the ventilator, two pressures are set. Firstly, the positive end expiratory pressure, PEEP, similar to that used in CPAP. As before, this pressure helps preventing the alveoli from collapsing. Secondly, the pressure that creates the push. This is the inspiratory pressure, which increases the size of each breath or tidal volume. The bigger the pressure, the bigger the push, the bigger the tidal volume. So let's assume that we set the PEEP at 10 centimetres of water. The pressure in the patient's lungs will not drop below this level. It's now the baseline pressure, if you like. Now assume we set the inspiratory pressure at 15 centimetres of water. Note that the inspiratory pressure is added on top of the PEEP. As the patient takes the breath, it causes the ventilator to initiate. It now increases the pressure until the inspiratory pressure is achieved. Once the inspiratory pressure has been reached, the expiratory valve opens, the pressure begins to fall, and the patient exhales passively until the pressure drops back to the PEEP level, where the valve closes to maintain the pressure. The inspiratory pressure can be adjusted until the desired tidal volume has been achieved, usually about 6 to 8 mils per kilogram. In addition to the pressures in both non-invasive ventilation and CPAP, oxygen levels must be set. For various reasons, this is frequently referred to as the FiO2, or fraction of inspired oxygen. The FiO2 is expressed as a fraction, so that 100% oxygen is expressed as an FiO2 of 1 and 21% oxygen is expressed as an FiO2 of 0.21. So, to summarise, CPAP uses high flow and positive pressure at the end of expiration to keep the alveoli open and improves oxygenation. Non-invasive ventilation gives a push behind each breath to increase the size of the tidal volume, which in turn lowers carbon dioxide levels. So that's it, a very basic overview of CPAP and non-invasive ventilation in under 5 minutes.
So thank you for that video, Kevin. So as we have seen, we can have what is known as CPAP, we can have what is known as NIV or NIPPV sometimes. So the difference here in short is that when we talk about continuous positive airway pressure ventilation, it means the patients are breathing but at a constant pressure during the inspiration and the expiration. Simple example ni kama vile uko kwenye gari linatembea ukatoa kichwa nje lipo kwenye speed ambayo iko ni constant, then you are breathing in and out at that constant speed. Can you try to imagine in your head the way it will be? You'll be able to breathe, but somehow, somewhere, in one of the ways, it will be a little bit difficult and uncomfortable, especially expiration. So the same way, one of the challenges we're getting with CPAP is patients are breathing at constant pressure, and somehow, some way, it's uncomfortable. more compared to NIV or non-invasive positive pressure ventilation, of which here the difference is you will set two pressures, the inspiratory pressure and expiratory pressure at different levels, so that one is high inspiratory and the expiratory is lower. Patient can breathe in and out during these two different pressures, and it become a little bit much more better for them and comfortable. So basically that is the difference, but purpose for both of them is just to decrease the work of breathing. As we have seen Mr. G in our presentation or in our case scenario, he has been on the high flow, but he was deteriorating, respiratory becoming too high. And we have done the ROX index and we have seen the number. He is in a high risk of failing with a high flow oxygen therapy. And maybe it seems like he can end up to need intubation, or maybe if you want to try to avoid intubation, you could use something intermediate, which is our non-invasive ventilation. So this is just applied to use the work of breathing, and also you can use it to avoid sometimes the intubation to end up in invasive ventilation. So those are more exemplified as we can see them there. And among all of those applications or indications that we have seen, when we talk about non-invasive ventilation, it is more applicable into two scenarios among all of them, where is evidence that it can help. This is COPD exacerbation and cardiogenic pulmonary edema, or the pulmonary edema due to the heart failure. The rest, the outcome is 50-50, but these two things are quite great and they give good outcome. And the BiPAP is similar to non-invasive ventilation, also have two different levels of pressures, and you can achieve it in different ways. But sometimes in BiPAP, the only thing which we'll add in there, you will be even having the chance or possibility to set even respiratory rate. Plus, even if they fail, there will be some sort of possibility to set respiratory rate. Great. So we say we can use it, but sometimes it could be challenging and there could be problems associated with it. So here, what could be the contraindications to provision or providing non-invasive positive pressure ventilation? Can we just mention in 15-20 seconds in our chat box, and then we can continue with our discussion. You can put anything in the chat box that you think that if the patient is in this specific condition, then probably it is not safe or it is not even allowed to use non-invasive positive pressure ventilation. So I think here Kevin will share with us some, okay, great. I think here I see from Dr. Solomon, unconscious patient. Many thanks. Yes, someone who is totally unconscious, you cannot put them in non-invasive positive pressure ventilation, because with them being unconscious, totally they lose the ability to protect their airways. Now we have seen those interfaces which can be used during provision of non-invasive positive pressure ventilation. They are very fitting face mask, very tight fitting face mask, and you are pushing in with a very high pressure from your machine or your ventilator. And someone who is unconscious, they cannot protect their airway. It means they have even no ability to have gagging reflex or swallowing reflex in a good way. So if they happen to have a lot of secretions or regurgitate with your machine pushing on top with high pressure, they can end up aspirating and end up even much more deteriorating rather than improving. So anybody who is unconscious is highly unlikely, it's not indicated to put them into non-invasive. And anybody post cardiac arrest, totally. They should never be put in the non-invasive ventilation or respiratory arrest from any sort of cause which can end up with respiratory arrest. The rest of other things which can be mentioned, we can meet with them in the literatures. They are called as relative. Relative, it means you can measure the benefit versus risk. You as a clinician, that for this particular patient, because of 1, 2, 3, as being a relative contraindication with provision of the non-invasive ventilation, what could be the risk and the advantage? If you find that advantage are more, you could give it a try. If you find that the risk are too much, better don't use it and proceed straight to the invasive by intubation and putting a patient in a mechanical ventilator. Thank you, Kevin. I think this one, they can read it, they can see there. So basically, that was it concerning the contraindications. So we are proceeding with our case. As we can see here, Mr. G was put in a non-invasive positive pressure ventilation for 1 hour with positive pressure support for 15 and a PEEP of 5. His FiO2 was set at 100% maximum total, and his respiratory rate remains to be 35 breaths per minute. He appears to be very, 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 very fatigued, and he's slumped over the bed and arouses only with shaking. That means it is even difficult to arouse him. Totally does not understand anything which is happening around him. So can we scroll up a little bit, Kevin? So, great. We can see some different things here, the way the circuit will be needed. So basically here, in short, we are talking about what are the setup, what are the things that you will need to be able to initiate and provide the non-invasive ventilation or non-invasive positive pressure ventilation in terms of CPAP. So here, basically, we need at least 3 things. You will need the right diagnosis that the patient is having this particular diagnosis. And we have said 2 diagnoses are supported by evidence that they have good outcome and result. COPD exacerbation or respiratory failure due to cardiogenic pulmonary edema. Then number 2, you will need right interface or right equipment. So you will have to have right equipment. We have seen the ones we can use, a very tight fitting face mask of different sorts, all the way to a nasal or nasal helmets, as we have seen in the video. So you need to have the right equipment to be able to provide your non-invasive ventilation. And the ventilators which can be used, they can be grouped into 2 groups. These are specific ventilators for provision of non-invasive ventilation, or you can use even these critical care ventilators that they have ability to provide non-invasive ventilation among one of the functions that they have in there. So either way, you can have one of them. And then the third component, the third part that you need is a skilled clinician. So you might have the right diagnosis, you might have the right equipment, but you don't have anyone who is having skills to initiate or to do or provide non-invasive ventilation. Still can be a risk. So clinician skills is as important as presence of right equipment and knowing that this is the right diagnosis for this patient to need or to be put into the non-invasive ventilation. As you can see in those pictures, different ways, different interfaces, and that's how you can happen to meet if you will be happening to be providing non-invasive positive pressure ventilation. So can we go up, Kevin? Great. So we had seen Mr. G, who was still yet kept into the non-invasive, but still he was not doing well. Respiratory rate basically did not change that much. FiO2 did not improve that much. And he remained tachypnic, but also even went more drowsy. He could be aroused by just even shaking. So basically, remembering and considering what we had received as a result of our ROX index up there, high chances that this Mr. G is failing even the non-invasive ventilation. Now, with that in mind, it means probably he might end up needing intubation to be ventilated invasively. So I think that was the last part. And in conclusion, I will just emphasize into the three components that you need for you to be able to provide safely the non-invasive ventilation or non-invasive positive pressure ventilation. You need to have the right diagnosis that has evidence behind it with good results, and that is either COPD exacerbation or cardiogenic pulmonary edema. Number two, you must have right equipment to be able to provide the non-invasive ventilation. And number three is clinician or physician skill. So skilled or trained personnel who is able to initiate or provide non-invasive ventilation or non-invasive positive pressure ventilation. And with a little experience, you might find that initiating non-invasive ventilation sometimes could be even much more challenging or a bit complicated than providing invasive ventilation. So clinician skills is as equally important as having the right diagnosis as well as having the right equipment. Thank you. I think I'll be taking it back to you, Saria, to proceed with the discussion.
All right, thank you so much, Dr. Gibbons. So Dr. Gibbons has been taking us through the non-invasive positive pressure ventilation. We have seen the difference between the CPAP, the BiPAP, the bi-level, and the PIP, and different parameters which can be set when you are using this non-invasive ventilation. So now this is the time for questions, clarifications. So if you have any issues, you can just raise your hand and ask the question. Or if you want to share an experience or you want to add from what we've presented, you are warmly welcome to this. Kwa mwenye maswali, mwenye nyongeza, anaruhusiwa kunyosha mkono tu, then tukawa na hiyo discussion. Karibuni wote for discussion. Hakuna maswali jamani.
So maybe when you're thinking about the questions, I could use maybe 20-30 seconds to narrate one simple thing that with provision also with non-invasive ventilation, also it could be associated with some complications, just similar as you have seen in the high flow nasal cannula. And one of it, we have seen the face masks that have been used. They are very tight fitting with the high pressure that you are giving in there. So with that high pressure, you can end up even with gastric insufficiency. You can end up with the facial trauma necrosis around there. It's quite discomfort for patients who are a little bit having troubles with the increasing abdominal pressure. They can end up regurgitating, and regurgitation with the high pressure that you are giving, they can end up even with aspiration. So other challenges that difficultness in who can be having abnormalities on their faces. So when you're providing non-invasive positive pressure ventilation, you have to remember that also it can be associated with some challenge and some complications as well, just like you have seen when you are going through the high flow. Thank you.
Thank you, Dr. Gibbons, for that addition. Seems like this meeting is being recorded. Seems like there's no questions or clarifications. Maybe I can welcome Dr. Kevin for announcement and then housekeeping issues.
Okay, thank you so much, Dr. Saria and Dr. Gibbons, and thank you for the nice, very good learning session. So we are closing our session, and with the following information, you can visit the Learning Resource Center to access this presentation, slides, and recordings at the following link. And also we'll share the link and recording of the session by email. You can join our WhatsApp group by scanning this code here or sending a message to assist through that number. And so we thank you all for joining. We invite you again for session 9. This is scheduled on April 22nd, 2022. And we will be discussing on pediatric consideration for oxygen and critical care. So prepare for April 22. And if you have any question before the session, you can send us through the following email, echo@assistinternational.org. So we thank you all for joining, and we'll see you in the next session.
Thank you, Kevin, and good evening, everyone. Yes, Karibu.